Okay, so we will start with labor analgesia. Okay. So generally, what are the different ways of giving labor analgesia? Zishan, if someone asks you, you are asked to give labor analgesia to a patient, what will be the things which you should be keeping in the mind?
There are pharmacological and non-pharmacological methods.
Okay. What else?
In the non-pharmacological, we have other than interventions.
Just a second. Try to pick the answer. What will be the consideration on which you will be choosing different modes of like you are telling non-pharmacological and pharmacological? Okay. So what factors will determine that what thing you should be using?
Sir, there are factors like number one, resources, and what kind of facilities do we have for pharmacological as well as non-pharmacological.
One thing. Number two.
Then patient preference.
Okay. Number two.
Patient's
Number
wishes. Patient's condition.
This
at
is
which stage of labor patient has presented to us.
Just a second. Just stop. I think this should be the first thing to be told, because practically this thing should be told the first, at what stage of labor patient is, whether patient is primigravida, whether patient is multiparous, whether the patient has any other condition in which different common modalities are ruled out. Okay. Yes. So you will be choosing different modes. The thing which you have told are not wrong, but they are not to be told at the first. Okay. Okay, so then if, for example, if it is first stage of labor, what level of analgesia you should be covering?
First stage of labor, we have to cover T10 to L1.
Okay, so what are different modes? Like you see, I know that because in the books it's written like that, non-pharmacological method, so people are very happy to tell. Okay, but in exam, as according to exam point of view, and as an anesthetist, you should be focusing on the things which are related to you. Okay, right. So what are different ways of giving labor analgesia in first stage of labor, for example?
Sir, number one, we can use opioids.
Okay.
We can use Antonox, and we can use epidural analgesia.
Okay.
Patient-controlled analgesia and patient-controlled epidural analgesia can also be instituted.
Patient-controlled analgesia, what medicines would you like to use?
Opioids like pethidine.
Pethidine in PCA?
For PCA, we can use fentanyl and remifentanil.
Yes.
Short acting.
Okay. Short acting, not pethidine. Okay, fine. So if we just concentrate on different other, like what are the consideration if you are using opioids? What will be the effects of opioids? If you are using IV, not for epidural, we will talk about epidural later on. What will be, for example, if you have given pethidine, for example, what should be your expectations? What can happen?
So sedation, number one.
Okay.
Respiratory depression.
Okay.
In extreme doses. Then there are effects on the fetus.
Okay. You have to use the meticulous word. What will happen? It will affect what? It will be affect the APGAR score. Okay. If you have given opioids to a mother and the baby is delivered, there will be effects on the APGAR score according to the medicine you have used, according to the dose you have used, and according to the last dose you have given. Okay.
Yes, sir.
So you have to inform the neonatologist that they have to anticipate accordingly. Okay. What are the common side effects which you can have when you are using opioids? One, you have told respiratory depression.
Pruritus.
Pruritus is more related actually it is more related to labor. Sorry, epidural. Okay.
Epidural.
So in epidural, pruritus is a common effect. What else? Respiratory depression, nausea, vomiting.
Nausea, vomiting, yes.
Okay. So
yes.
like usually like according to the resources, whatever medicines are available, you are using them. Okay. Okay. So now come to labor, this one, epidural. Okay. So how will you explain the patient about epidural? What will you tell? What are you supposed to tell about epidural? Because this question is being asked in labor counseling. Okay. In the counseling station as well, that how will you, so actually in the labor epidural, you have to tell these incidents, that blood pressure can fall, there can be incomplete or partial effect or failure. Okay. If dura is punctured, there can be headache, and then the neurological side effects and the uncommon but serious side effects. Okay. You will find this in the folder, in the articles folder, so you can use it. And you have to explain that there can be fall in blood pressure, but we will give some medicine, or we will give some fluid, so blood pressure will be maintained. Okay. If there is incomplete, we can give some extra dose, we can withdraw we can relocate the catheter in the way that maybe we will be able to cover that incomplete effect. Okay. And for PDPH, you have to explain even about the possible management of PDPH and what can be the consequences, and the rest of the things as well. Okay. So this is one thing you need to know. This is a talks station as well. They can ask you in the talks. What else? What else you need to do before giving epidural?
Coagulation status.
Okay, fine. What else?
Patient's hemodynamics, fluid status, preload.
The proper positioning.
Proper positioning.
Explaining the patient about the procedure. Especially you have to counsel that if there is a pain, you have to inform so that you will stop the needle handling. Okay. And then because giving epidural in a labor pregnant patient in labor, pregnant patient separately, and pregnant patient in labor, the epidural pressure is quite high. Okay. Can someone tell about the pressure? I don't remember the exact pressure, because usually it's negative. It can go up to, I think, 15 millimeter of mercury. I'm not sure. Please just recall. I cannot recall. Someone can share if know the number, or Google it and tell us. Okay. Then another thing is that what concentrate, like you have put the epidural, you have cited it. How will you initiate?
So usually we first give a test dose.
Okay, test dose of what?
This test dose can be given of bupivacaine, diluted bupivacaine, or of xylocaine.
Listen, Zishan, you mentioned the things which are maybe written somewhere, but they are not the common things. What is the concept of giving bupivacaine as a test dose? Just tell me.
Sir, bupivacaine.
Bupivacaine is not at all. If you are giving it, you are giving it. Don't say that it is test dose. Test dose is given with xylocaine with adrenaline, and you have to rule out whether this catheter is IV or intrathecal. Okay.
Yes, sir.
I have never heard. From where have you read this bupivacaine as test dose?
I'll look into it, sir. Our professor also told us that because using adrenaline used to be an old school of thought.
That is something else. No, it's not old school of thought. It is the correct school of thought, but the problem is that it is not very reliable. Why? Now tell me the
Because the
answer.
patient is already having patient can be having tachycardia. We only see
Because
tachycardia
of
and hypertension with adrenaline.
tachycardia. No. What else we see? What else we should be seeing?
The Xylocaine effect is
No,
that
no,
the
no, no,
patient
no, no,
will
no,
have
no, 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 no. Zishan, concentrate on
adrenaline.
adrenaline. I'm not talking about xylocaine. Xylocaine is miskin.
Adrenaline is just tachycardia and hypertension.
No, you see that's the problem. That's the problem, and we don't discuss. Please, I'm not expecting that you are not aware of this thing. Anyone else, please? What are the things which you are focusing when you are using epidural test dose with the adrenaline? One thing he's saying tachycardia, he's right. Okay, fine. But actually, we are looking at the ST changes.
Right.
Okay. So ST changes we are looking at, and these are more reliable than tachycardia, actually.
What will be the effect on ST changes?
I don't believe in it. I don't know. But it is written. You can check it out. Okay. I think there is some elevation or something like that, because I never use it. So that's why I forgot. But it is like that, I think. There are some ST changes. You can look into it. Tachycardia is not reliable. Okay. Because labor in laboring patient, there can be episodic tachycardia with the presence of the pain. Okay.
Yes, sir.
So
I just found the bupivacaine test dose is written in Oxford.
So I think you should seriously think about mentioning Oxford, because Oxford things are Oxford. I have never heard about it. I can guarantee
usually
you
whatever is written in Oxford is written in ATOT articles. It's the same. I'll look into the article.
You will look into it, but I tell you that in our exam system, you discuss it with some of your examiner. What is the role of bupivacaine test dose? Just tell me which percentage will you give? How much dose will you give? What will it tell you?
0.1%.
Listen, I will prove you logically. You prove me logically. What is the advantage of giving? What is the purpose of giving test dose?
The test dose is given to see if it's intrathecal or intravascular.
Okay, so just tell me 0.1%. How many ml you will give?
5 to 10 ml.
5 to 10 ml. So if in how much time it will tell you that it is intrathecal?
In 2 minutes, 1 to 2 minutes, like just in spinal.
Okay, so 0.1% will give what? 0.1% is giving you very like crude sort of analgesia.
Sir, but the 0.1%, if we are giving 5 to 10 ml, it will be 5 to 10 milligram.
Okay.
That will be equivalent dose, equivalent to what we give in spinal usually.
And how much time it will take? The purpose of test dose usually is to get the results in few minutes. Okay. So it will take much more time because it's very diluted dose. So it's not a very good idea at all. Okay.
Right.
So you don't need to mention it. Just tell me one good reason to tell that bupivacaine is to be used. It's very difficult to prove to defend.
Right.
Maybe it is written. I don't
deny. Should always be given like Xylocaine and
Xylocaine. Why?
It should
I'll
be
tell you the
told
reason.
in the exam.
Yeah, because thing is that not everything, yes. The purpose of giving test dose is that you are checking the results very quickly. Okay. So bupivacaine, if you will mention it, if you ask me, I never use test dose and I always give lidocaine. Okay. So because if it is intrathecal, it will tell you, and there is no reliable method. Only is to give incremental doses. If you want to be sure that you are not IV, it is better to give incremental doses. That's the only thing which can save you practically. But in the exam, you have to mention that you will be giving it slowly and this. Aspiration with aspiration check. Yes, another concept. How to check the aspiration? How to check the aspiration through epidural? What is the correct way? If you want to check it out, whether there is blood aspirate or there is CSF aspirate, How you should be doing it?
By through the catheter, through the epidural catheter, when we just let it fall under the action of gravity, not by suction.
Okay. What else?
Other one is suction.
If you want to use, which syringe you should be using?
Which syringe?
Yes.
Routine 5 or 10 ml syringe, I think.
I think it is better to use a smaller syringe, which will give you a better idea. If you are using a 10 cc syringe, you will not be able to appreciate maybe. It is better
3 ml
to use 3 ml.
3 ml or 5 ml. Right.
Preferably 3 ml. Okay. Because in 3 ml, you are using a very slight pressure. In 10 ml, you are actually aspirating with very high pressure. So it can give you a false result. Okay. So it is better to use 3 ml. Okay. And these are some things which they can ask you, but my suggestion, don't use bupivacaine. Even if it is written, examiner will catch you because it's not the first, logically it's not a good correct thing, because you have to give the thing which is giving you effect quick, and you are avoiding a bad medicine. Why you are not giving direct bupivacaine dose? Because you are claiming that bupivacaine, if it is going IV, it's not a correct thing. Why you want to use it? Okay, so logically it's not a very nice thing. Anyways, we move forward. So you have given a test dose, you have confirmed that you are not intrathecal. Then how will you start? How much dose would you like to start?
10 to 15 ml
10
of
to
0.1%.
0.1%. How did you calculate 10 to 15 ml? Which segment you want to cover? Which level would you like to give? Put the epidural when you are giving for first stage of labor?
We have to cover from T10 to L1 basically.
Okay,
so
what
if
segment
we
would
have
you like to
put the epidural at L3 level, L3, L4 segment.
Why you want so low? Why you don't want to give at T12, for example?
Sorry. Okay, the catheter must be up. Of course, right. So T10, 11, 12, 1. There are 4 segments basically from T10 to L1, and we usually give 2 ml per segment.
Okay.
Rather, it's below. It's less than 2 ml per segment in obstetric patients because of the congestion, venous congestion.
So if, for example, usually you have to cover, like for example, if you want to give it up to T10, you can give it at T12. So you will be calculating from T10 to, you will go 3 segment down. Okay. So you will be calculating, and you have to cover T10, 11, 12, L1, and L2. No.
And L3.
Okay. So you have to, because it will trickle down. So that's right. How, and you should be starting gradually. Okay. And at what dilatation level you should be giving ideally?
After 4 centimeter of dilatation.
Just a second, please. Okay. Okay. So usually you should be giving it at the early stage of labor, because as labor is progressed, it is difficult to place. Patient will be uncomfortable, and actually you are wasting the utility. Okay. As late you are starting it, as much you are using its utility. Okay. And you should be giving usually with the syringe pump, 0.1%.
$10 to 15 ml per hour.
Yes, with the syringe pump. With the syringe pump you will give. Have you ever seen in Pakistan this syringe pumps? In maybe some of higher setups you will find. And how much fentanyl would you like to add? Usually? Usually it is 2 mics per ml. Okay, 2 mics per ml. You have to add 2 mics per ml, and then you will be starting at usually if it's written like from 3 to 20 ml per hour. Okay, and usually you start it at 5 ml and then you gradually increase it according to the. And if, for example, they are troubleshooting, they are calling you after 1 hour, patient is started having pain. So what would you do?
After 1 hour?
Yes, for example, after 1 hour, patient is now 6 centimeter dilated. She is primary. Still, she will take some time, and they have called you. So what will you do?
We can top up.
Immediately without any evaluation, you will top up? Would you like to evaluate the level? Would you like to check what level is involved? Would you like to see whether this is the real pain? For example, if it is involving the somatic element.
Yes, sir.
Okay. So what options you have? You have option to give a sitting dose. You will make the patient sit, and you will give a bolus of 10 to 15 ml. Okay. Or what options as, because now you have to add the second stage labor. Okay. So you can, what options you have now? Anyone else would like to say something? Zishan, what options now you have?
So we are talking about epidural?
No. I'm talking about the management of the patient.
We can start, sir, we can start the remifentanil because the epidural may be partially placed.
Listen, Atik, try to understand what's the reason. What you have first, you have to evaluate, and then if it is sensory segment, what options you have? Would you have you heard of pudendal nerve block?
Yes, sir. Nerve block, yes, sir.
Have you heard of saddle block?
Yes, sir.
So you have to tell the examiner. Practically nobody does it, but this is the answer. The options you have is the sitting dose, or this pudendal nerve block, or the saddle block. Okay.
But these pudendal or saddle nerve blocks can be used along with epidural.
Why? What's the issue with it?
Okay, I thought if epidural is there, other things won't
even if it is effective or no. It's haram to give Antonox. If it's haram to give any other modality, am I right? You cannot use any opioids, IV. You cannot do anything else.
Please, sir, I didn't mean that. I just meant for the other blocks.
No. You can give. Okay, you can give, or even there is you can have the single shot, as Jamil mentioned. You can have a single shot at spinal or saddle, whatever you want to say. Okay, because now the sacral segments are involved. The S2, S3, S4. Okay, so first of all, you are giving a sitting dose. You are making the patient sit down, and then you are giving, and let the patient sit for a while. So it is preferably not going too high, and it is settling down more in the lower part.
Yes, sir. Assalamu alaikum, sir. Sir, actually, I joined just now. When the patient complained of pain, first of all, as you told, first we go to and assess the patient, and we ask the patient which side you feel the pain. Sometimes it's a patchy block, or sometimes you can better that in epidural space there is some connective tissues which can what it has to spread the local anesthetics. And sometimes the patient complained that the left leg is already numbness and I feel right sided pain, or sometimes the patient is in severe contractions on second stage and there is a somatic element of the pain. Then you have to give the extra dose of this epidural. First try if you give 0.5% lidocaine and in 5 to 10 ml, and depends upon the site of the pain. Sometimes you give the patient feel the right side pain, you turn the patient to right side and give her a good bolus of 0.5%. It immediately will affect and it will give you the result that the local anesthetic is not spreading all the area, not covering all the nerves. And if definitely not going down means there is also some defect in spreading the patient in epidural. If you give the bolus, maybe it's all go up, not going down, then you have give the patient and set the patient seat for 3 to 5 minutes, and patient will relieve immediately with 0.5% lidocaine. And if there is no spread due to some safety in the epidural, then you can go with 1 ml 0.5% bupivacaine. It will be single shot, it's short acting, and 1 ml will not go high, and it will not give the motor. It will dilute in the CSF, and it's also will relieve the pain. And the other options, definitely it's not the ideal, pudendal nerve block or some cervical block. It's definitely difficult by anatomically, and it's difficult. It's in this second stage, but that times we also encourage the patient to take Antonox breath. It will also relieve. And some midwives, they give the pethidine additional 50 to 100 milligram intramuscular, and definitely it will not affect immediately, but it will take time after 10 to 15 minutes, and the patient will relieve the pain. Some centers, they also advise remifentanil infusion 0.03 to 0.05. It's awake sedation and very short acting. It will not hurt the fetus, but there should be presence of anesthetics during this remifentanil infusions, because it can cause different side effects like chest wall rigidity, deep sedation, apnea, but up to 0.05 mg per kg per minute, it will be safe. I think this will relieve the patient the pain in the second stage.
Yes, so Jamil has elaborated the quite sophisticated things, okay? Because in Pakistan, these things are not available. I have a question, and I would like, Atif, you have raised the hand. First of all, you tell your question, please, and then I will ask you this question. Dr. Atif?
Sir, I just wanted to, yes, I'm here. I wanted to ask about the dose of bupivacaine for this single shot to cover the somatic pain in second stage of labor. I think Dr. Jamil answered that 1 ml of 0.5 bupivacaine, 0.5%.
There is no, just like you consider this patient you are giving it like a hemorrhoid, for example, okay? As much as dose you are giving for saddle block, you will give it, okay? And but you have at any time, because you are giving a lot of local anesthetic, so you have to take care of the toxic dose, okay? You have to look at the patient. So now my question to you is, how will you evaluate the level of block? When you are giving any regional anesthesia like spinal or epidural, how you assess the level? That what level patient has achieved? How will you check? What 3 tests you need to do?
Sir, first of all, the effect we get is the autonomic blockade.
So how
we
will
check
you check
by
autonomic?
the differentiation of heat and cold sensation. For that, we normally use the cold spirit swab.
Or cold. In centers, we have cold ice in that we put it in the gloves, okay? And then the midwives, they are very expert. They are checking the level, okay? It is difficult to differentiate with hot, so usually they use the cold. So it's, if the patient is able to differentiate the cold, it means there is no block, okay? So the other things, how you check the motor?
Secondly, then we have the sensory blockade, and at last we have the motor blockade. For motor blockade, we have a Bromage scoring system. I don't exactly remember all the points of the Bromage score, but that assesses the levels of motor blockade starting from the knees and hip extension and flexion.
Yes, like in you are, whether you are able to lift the leg or whether you are able to flex the knee, or whether you are able to not only moving the foot. Okay. If you are able to lift it, you would no block. If you are able to flex the knee, but you are not able to lift it, it is other stage. And if you are not able to flex the knee, only you are able to move the legs, if this is the last. Dr. Kaisar Sindhu, please can you switch off your camera? Your camera is on. Kaisar Sindhu, please switch off your camera. Thank you. Okay, you understand, Atif?
Got it, sir.
Okay, so this is a Brahmana scale. So one is the checking the autonomic with the cold sensation. The number two is to just check the sensory with the cotton bud or anything. And the third is the this motor. Okay.
Sir, what is the best method for sensory?
Sensory, I think touch. What else? If anything else, you can please tell. With the cotton bud.
Right.
What else you have read? If anyone can add it to it.
Yes, sir. You can check with the tooth forceps or pinprick.
Yes, you can do like that as well. Okay. So this is the troubleshooting. Usually you have to start with the assessment and then management. If it is it was effective previously and now you have to correlate the sequence of events, and then accordingly you will manage. Another thing will be that now this patient is going for surgery, cesarean section. First of all, my question is that what is the effect of epidural on the delivery or possibility of cesarean section? Is it related to more incidence of cesarean section? Yes, Atif?
No, sir, it is not related to in increasing the incidence of cesarean section, but it's documented that it may prolong the duration of second stage of labor.
Number one, and number two?
It may prolong the duration of second stage of labor to some extent.
Instrumental delivery, more chances of instrumental delivery. But cesarean section, yes, according to the data available, it's not related to more chances of cesarean section. Okay.
Exactly.
So now you are there, you had a patient with epidural, and now that patient is going for cesarean section. What will you do? Please, Atik bhai, you tell.
If we are having epidural in place, we can increase the dose and just give it to
increase the dose.
Sir,
what do you mean by increase the dose?
Sir, we have given the analgesic dose. If for the
you tell me what you will give. This is not an answer. Please be very specific. What will you do now? Patient was receiving it 0.1%. Now you are asked to convert the patient for cesarean section. What will you do?
Sir, the dose is we will just shift the patient to the operation theater, and sir, after giving boluses, we can increase the dose just for the.
No. In this way, you will be able to prepare the patient after 1 hour. Did you mention that there can be fetal bradycardia or fetal distress? In that scenario, would you like to wait like that? Would you like to discuss with the obstetrician?
We will discuss with the obstetrician. Sir, we will top up the we can if we will discuss the situation with the obstetrician. If she is saying that we have time, then we will top up the epidural with the anesthetic doses.
What will you do now? You see, you have to be very specific. In that way, you have to mention that I will be discussing with the surgeon. What is their plan? This is number one. Number two, according to the stage, like what is how much urgent the surgery is. This is number two. And then now the difference is that before you were giving sensory. So you were giving very diluted dose. Now you have to make it surgical anesthesia by giving motor block. So you have to use 0.5%. And before you were covering it up till T10. Now you have to cover it up to T Till what level you have to cover?
T4.
T4. Okay. So you have to cover up to T4 autonomic. So you have to give a concentrated bolus with which drug would you like to use and how many mils you will give?
Sir, we will give Lidocaine 0.5%, sir. And sir, we will
only, or would you like to give something else as well?
Sir, we can add adrenaline, like with the Xylocaine, we can add adrenaline.
Just a second. Adrenaline has, what is relationship of adrenaline at this time?
Sir, just to fasten the block because they are doing sector.
No. Adrenaline is not supposed to fasten. For fasten up, what
to prolong. Sorry, sir. Because it causes vasoconstriction.
No. Listen. At this time, it's not your priority to prolong it. It's a short procedure. How much time usually takes? Cesarean section, you want 4 hours surgery?
No.
Why? Then why you want to prolong it? You want something else. You want to hasten up the effect, so you have the opportunity of using lidocaine. Okay, you can give combination of bupivacaine with lidocaine. You can give 10 ml of lidocaine, 2% or 1%, or this one 0.5% of bupivacaine. Okay. Plus, you have to mention in the exam that I will be considering the total dose which a patient has consumed in the last few hours. Okay. This is one thing. Another thing is that, like you were mentioning, the hasten up. To hasten up, you had to add what thing? Bicarb. Because bicarb will make the pKa of the solution in the way which is required for the early onset of action of local anesthetic mixture. Okay. Epinephrine is causing vasoconstriction and it is reducing the absorption from the site at where you have injected, and it will prolong the effect. It has more effect on bupivacaine or lidocaine.
Lidocaine.
It has not much significant effect on bupivacaine. Yeah. Why? What is the reason for it? Because bupivacaine is highly protein bound, and the duration of action of bupivacaine is because of its high protein binding. Okay. But would you like to give still would you like to add epinephrine? If you are using bupivacaine, still you can get one effect, which is good. What is that effect? Yes, Dr. Abdul, please. Decrease systemic toxicity.
Okay? We can decrease the risk of
because when you are giving epinephrine, there is vasoconstriction. Okay, so the absorption will be slowed down. Okay, so the chances of toxicity will be decreased. So you have to be very specific. Epinephrine use with bupivacaine, I have just explained to you, because duration of action is usually because of protein binding. So bupivacaine is highly protein bound, so it has long duration of action and slow onset of action because its pK is 8.1. pKa of lidocaine is 7.7 or 7.8. So it is more near to physiological pH. So there is more unbound lidocaine at physiological pH. So it is causing quick effect. Bupivacaine pK is 8.1, which is away from physiological pH as compared to lidocaine, which is 7.8. Physiological pH is 7.4. So 7.4 is nearer to 7.8 and it is far away from 8.1. So the medicine whose pK is 8.1, it has less unionized portion. So unionized portion, you can say it's a loving portion or caring portion, or the patient which is diplomat is not fighting with the body. So the body is accepting that portion. So this is the concept of using lidocaine. So for that, you add bicarb. Okay. If you just recall the medication, that you will see that it is written lidocaine hydrochloride. or bupivacaine hydrochloride. What is the reason for making it acid? Why the commercial preparation is acidic?
To increase the shelf life.
Very good. To increase the shelf life, because basic solutions are unstable. Okay, they are destroyed. So it is better to have acidic solution which are more stable, and it is increasing the shelf life of that drug. Okay, so this is the whole concept. So now we have discussed this thing, so we can say a few words. What else then? This opioids we can give. Opioids we talked. Epinephrine we discussed. Bicarb we discussed. What else you can add to increase the quality of the block or prolong the effect? Other than
Alpha agonist.
Alpha agonist
we can use the opioids.
No, opioids I have told you. Other than opioids,
So we can use dexmedetomidine and clonidine.
Yes, dexmedetomidine or clonidine. Now clonidine nobody is using. So dexmedetomidine can be used, and it will increase the quality of the block, but it will increase the chances of hypotension and bradycardia, because it itself is a medicine which causes severe bradycardia. Okay, so this is you should be knowing when you are using this one, dexmedetomidine. Okay, so I think these are the aspects which should be knowing, because they will be asking you what will you do if it is ineffective, how will you manage if the same patient is going for surgery, but how will you manage, what are the different options, and the other options I am not going to discuss because they are written in the books. Antonox, aromatherapy or hydrotherapy or massage or hot, whatever, you can tell anything. These are not in our domain actually. Okay, only one thing which you should be knowing, whether they can ask you in other scenario as well, is Antonox. What is Antonox?
Antonox is a mixture of oxygen and nitrous oxide. It is 50% oxygen and 50% nitrous oxide.
Okay.
Used as analgesia for the labor.
Okay. Is it a normal combination or if it is something else? What is pseudo-critical temperature? Anyone knows about it?
So when two mixtures,
below the less.
One person, please. Usman, please tell.
Sir, pseudo-critical temperature is basically when we mix the two gases, their critical temperature changes. So that is called a pseudo-critical temperature, and at this temperature, the two gases they separate at a point which is called pointing effect.
Okay, because these two gases, one is in liquid form, okay, and other is in gaseous form. So you are combining it. Okay.
Yes.
So because this is not our topic for today, we will discuss Antonox in detail some other time. But these are the basic information we should be knowing about it. The concept of this pointing effect, as you told, what is pseudo-critical temperature, okay, and what are the troubleshooting. Like if you have an Antonox mixture, what can happen? What are the problems which you can face when you are giving Antonox?
Sorry, below this 6 degree centigrade, the nitrous oxide may remain in the liquid form, allowing the oxygen to be exhausted first, after which the cylinder will delivery 100% nitrous oxide with no oxygen. Hypoxic mixture can be given.
Hypoxic mixture will occur. So what is the way? If you are placed in at a low temperature, you have to mix it up. Okay, you have to mix it up so that
the horizontal horizontally placed cylinders. You have
Yes,
to place
you have to
this
place it
cylinder.
horizontal. Okay. So this is a few words about Antonox. Okay, so any other question related to labor analgesia? Theoretically, you also use the word this combined spinal epidural. Okay. What else?
Sir, I have a question.
Yes.
There was a scenario we talked about when we had the epidural catheter placed in, and we were about to proceed for an emergency cesarean section. I don't remember exactly, but I read somewhere if the patient is one of the factors. If the patient is primiparous, we can give a combined spinal epidural, and if the patient is multiparous, we can give the single short spinal. Is it so?
Actually,
This is the first part of my question, and second.
Listen, I will answer this part. Listen, these options, how many times we are using combined spinal epidural for labor? Usually we are not using it. Okay. But when we are facing this question in exam, in the list, you have to tell combined spinal epidural as well. Okay. Yes. What else? What else you were asking?
But does it relate to the primiparity or multiparity of the patient?
This is not our domain. Okay. Yes, you will anticipate in primary gravida there will be more time you need to give anesthesia, for example. Okay. But actually usually this is not the prime thing you have to decide. Like even primary can deliver or go to cesarean section, or even multiparous can go proceed and can have fetal distress, and immediately they need to take for cesarean section, or immediately multiparous can also take more time. So usually we say that when it is primary, you have more time. Okay.
So may I tell a bit?
Yes, please.
Actually, sir, I heard a talk by General Liaquat on this very topic. He said that actually the decision when an epidural in place and a working epidural in place during labor, and we have to convert the patient to cesarean section if the patient has to be rushed for a cesarean section. The only thing that matters if you want to use a spinal or an epidural top up is the timing. He said that the fastest action will be achieved by if you top up the epidural with a 0.5% bupivacaine in the labor room, and during the shifting of the patient, she will achieve the surgical anesthesia, and as soon as you are there, you just drape the patient and you can proceed with the surgery. While in the case of spinal, where we have to place spinal when she has been shifted to the operation theater, and then when we are draping and then sterilizing and disinfecting and all that, and when the spinal is given again, then 2 to 5 minutes are required for the spinal action to be achieved for surgical anesthesia. So the best option is to give the top up dose in epidural in the labor ward, and then you can achieve your surgical anesthesia while the patient is in OR.
Sorry, Janab, I give you my practice. It is even more better than Dr. Diakar. When they announce the patient is going for CS, I go to the labor ward, give 1% lidocaine 5 to 10 ml, 5 ml, and 100 mics of fentanyl with 10 ml of 0.5% lidocaine. Sorry, 0.5% bupivacaine. Fentanyl and the lidocaine, its effect immediately, and the patient reach to the OR table. Patient already have patient already pain free. And for a quick onset, we used lidocaine and fentanyl, and it take 3 to 4 minutes. During this, the patient transfer from labor ward to the OT table, and then started effect of bupivacaine, because bupivacaine takes at least 10 minutes. And even if you give in the labor ward, maybe in Pakistan it's take 10 to 15 minutes, but not here. Here they take 3 to 5 minutes. It's a labor ward is attached to the labor OT.
Okay, just a second. I will interrupt for a second. Both of you are right. I will say that the only thing which both of you are missing is that when you are giving a dose in labor room, and you may be during the transfer, it will depend how far is labor room from the OT. This is one thing, and how will you monitor the patient. Okay. So when you are telling an exam, practical conduct of anesthesia is something else. In the exam, you don't need to go in too much details. Nobody is asking you how you do it. They will be asking you the basic safety. Basic safety, if you are giving it, your answer will be that you have to discuss with the surgeon how much time you have, and you will make the plan accordingly. If you are giving a dose in labor room, you have to keep very meticulous monitoring, and even you can give some intramuscular vasopressor to counteract any possible hypotension. Okay. And the other thing which Zishan mentioned is that you need the effect quick. So it is better to make a combination with lidocaine and bupivacaine. Bupivacaine, if you are giving only 0.5%, you need to give higher dose, which can cause more complications. So it is better you make a combination with lidocaine, or with you can add some epinephrine, you can add some bicarb, and you can make a combination of lidocaine and bupivacaine. Okay. So in exam, you have to be very safe. Okay. So whosoever mentioned, you have to subtract, and whatever you have to tell in the exam, remember, no examiner is going to pass you or make you like a gold medal, or if you are telling something heroic. They will pass you or give you credit if you are safe. Okay. So in any of the modality you are using, any of the way you are controlling the things, the basic thing don't forget, which is the safety and monitoring of the patient. If you are giving it, tell the patient, you have to keep the patient highly monitored, because patient can have hypotension. So if you are telling that I will do this, tell about what I have told you, intramuscular vasopressor like ephedrine or phenylephrine. Okay. So this is, I think, what you need to do.
Yes, agreed. But you, sir, Zishan, how the monitoring here, definitely, even from labor ward to the OT.
Jamil, you are absolutely, I'm sorry to interrupt you. Yeah. Actually, I want to finish the discussion.
Yeah,
so I'm trying to hurry up. Only thing which I am telling you, that in the exam, forget that what you are doing. Okay.
Mm-hmm. But I have to mention. Yeah.
You can mention it. You can mention it that you will discuss it, and this is one of the options. When they are asking you this question, which it will be written in their key. What are the different things? If you are telling that you will be shifting the patient in the OR, and then you are giving it bupivacaine 0.5%, it will take 15 to 20 minutes. So how will you conduct an anesthesia immediately?
No. Yeah, that's why I told. I give a combination there: bupivacaine, lidocaine plus fentanyl there.
But you did not mention about the monitoring. So if you tell this routine,
I have to mention. Yeah, because they will routinely doing the monitoring. Yeah.
They will make you send another 15,000 to them. Okay.
I think for me more.
Yes. Okay, everybody. Any other question for labor epidural? We will continue. We will try to finish the rest of the obstetric anesthesia in the next section. Okay. Any question? Any comment about labor analgesia? Okay. Bye. Thank you. Salam alaikum. Yes. Sorry. This if you have patient having any bradycardia, fetal distress, you will not wait and you will convert into GA. This is the thing which I missed. Okay, everybody, thank you. Bye.
Allah Hafiz.